Welcome everyone. This is Dr. Hani Nadeem. In this lecture, we will cover the anatomy of the pectoral region and the axilla. In this region, we see superficial structures, 4 muscles, and a fascia called the clavipectoral fascia. First, the superficial structures. At first, there is a muscle called the platysma, which descends from the neck down to the level of the sternal angle. It lies in the superficial fascia. And there are cutaneous nerves, as you can see. Those coming from above are called supraclavicular nerves. They are branches of the cervical plexus. They are 3 groups: lateral group, intermediate group, and medial group. And there are anterior and lateral cutaneous nerves. These are branches of the intercostal nerves of the thorax. The anterior are the terminal branches of intercostal nerves. The lateral are just branches of the intercostal nerves. In addition, we see this groove between the deltoid and pectoralis major. It's called deltopectoral groove. It contains the cephalic vein and a group of lymph nodes called deltopectoral lymph nodes or infraclavicular lymph nodes. The first muscle is the pectoralis major. It's a large flat muscle that covers the front of the chest. It arises from the medial half of clavicle, half the breadth of the front of the sternum, from the upper 6 costal cartilages. It collects into a flat tendon, which is twisted, made of 2 laminae. The clavicular head joins the anterior lamina, and the sternocostal head joins the posterior lamina. This tendon is inserted into the lateral lip of the bicipital groove of the humerus. The nerve supply is through medial and lateral pectoral nerves, and its action is: number 1, flexion of the shoulder; number 2, abduction of the shoulder; the third action is medial rotation. The fourth action is it helps in climbing. How is that? When you fix the insertion, when the arm is raised above, it helps to pull the thorax and the trunk upwards when climbing. When we remove the pectoralis major, we see 2 muscles. This triangular muscle is the pectoralis minor. Above here, just below the clavicle, there is the subclavius. The pectoralis minor arises from ribs number 3, 4, and 5, close to their cartilages, or maybe ribs 2, 3, and 4. Its insertion here in the coracoid process of scapula. It is supplied by the medial pectoral nerve, which pierces it. Its actions are to protrude the scapula, or protraction of the scapula, acting together with the serratus anterior, and depression of the shoulder. This small muscle under the clavicle is the subclavius. It arises from the first rib close to its cartilage. It's inserted in a groove on the inferior surface of the middle third of clavicle. It is supplied by a special branch from the brachial plexus called nerve to subclavius. It does not have really any, it does not cause any movements. It can be considered functionally as a ligament because it helps to stabilize the shoulder girdle. This muscle with many teeth on the side wall of the thorax is the serratus anterior. It arises by 8 fleshy digitations from the upper 8 ribs. It wraps the thoracic wall, running in front of the scapula all the way till its medial border, where it gains attachment. Its lower 5 digitations are inserted in the front of the inferior angle of the scapula. It is supplied by a special nerve from the brachial plexus, which is called long thoracic nerve or nerve to serratus anterior, which descends on its surface. Its actions are a protraction of the scapula acting together with pectoralis minor, like when pushing the sword forwards, depression of the scapula, also with pectoralis minor and lower fibers of trapezius. In addition, its lower 5 digitations with the trapezius help rotation of the scapula while abducting the arm above 90 degrees. The fascia that connects the two muscles, the pectoralis minor and subclavius, is called clavipectoral fascia. It lies deep to the pectoralis major. Its attachment is to the following. As it goes up from the pectoralis minor to the subclavius, it splits to enclose the subclavius and gets attached to the borders of the subclavius groove of the clavicle. Below, it splits to enclose the pectoralis minor and reunites again to form the suspensory ligament of the axilla, which is attached below to the axillary fascia, pulling the skin and this fascia upwards, making the hollow of the axilla. Medially, in the part between the subclavius and pectoralis minor, medially it is attached to the first rib and costoclavicular ligament here, and laterally it is attached to the coracoid process. This part is called costocoracoid membrane. This part is pierced by many structures. One structure from each different structure, like one nerve, one artery, one vein, lymphatics. So let's see what they are. The nerve is the lateral pectoral nerve. The vein is the cephalic vein on its way going to end in the axillary vein. There is an artery that pierces the fascia coming from the axilla. It is a branch of the axillary artery called thoracoacromial artery. And the lymph nodes, lymph vessels, drain the deltopectoral lymph nodes and pierce this fascia to reach the axilla to end in the axillary lymph nodes. Its functions are protection, and it makes the axillary fascia or suspensory ligament of the axilla that deepens the skin of the armpit. Now let's try to answer this question together. First, you try by yourself, pause the video, try to answer it yourself, and then replay the video to hear the answer. Okay, which of the following structure pierces the clavipectoral fascia? All right, the answer is lateral pectoral nerve. The medial pectoral nerve does not pierce the clavipectoral fascia, it pierces the pectoralis minor. The lateral thoracic artery is not the artery that pierces it, it's the thoracoacromial artery. The basilic vein does not pierce the fascia, the cephalic vein is the one that pierces it. The long thoracic nerve has no relation to the clavipectoral fascia. As a matter of fact, it's deep to it. In the second part of the lecture, we will be talking about the axilla. We will define what is the axilla, what are its boundaries, and what are its contents. Now, what is the axilla? It's the pyramidal space situated between the upper arm and the chest wall. If you remove the skin of the armpit, it lies above that. So it's hidden anteriorly by the pectoral region, posteriorly by the scapular region, laterally by the arm, and medially by the chest wall. It has an apex. It is pyramidal in shape. It has an apex above. It's an opening leading to the neck. It has a base, which is made by the skin and the axillary fascia. It has a medial wall, a lateral wall, an anterior wall, and a posterior wall. The anterior wall is made of 2 layers. The first layer is made of pectoralis major. Its lower border forms the anterior fold of the axilla. The second layer is made of pectoralis minor, subclavius, clavipectoral fascia in between, and suspensory ligament of the axilla. The posterior wall is made of three muscles: subscapularis, which lies in front of the scapula; teres major, which is a muscle of the shoulder region here; and latissimus dorsi, which is a muscle of the back going here to the bicipital groove. The teres major, bicipital groove go as well as the pectoralis major to be inserted in the bicipital groove. Teres major, the lower border of teres major, forms the posterior fold of the axilla, which is lower down than the anterior fold. The medial wall is made of the upper 4 or 5 ribs with the intercostal muscles in between them, and the upper digitations of serratus anterior with the nerve to serratus anterior descending on it, as you can see here, or you can see also here. The lateral wall is narrower than the medial wall because the anterior and posterior walls converge towards the humerus. It is made of the upper part of the shaft of the humerus, the coracobrachialis muscle, and the short head of biceps muscle. These two muscles of the arm arise from the coracoid process. The apex is a triangular opening called cervico-axillary canal. Here it is. It leads from the axilla to the posterior triangle of the neck. Anteriorly, it is bounded by the clavicle, posteriorly by the upper border of scapula, and medially by the outer border of the first rib. It transmits the brachial plexus, the axillary artery, from the posterior triangle to the axilla, and the axillary vein and lymph nodes from or lymphatics from the axilla to the posterior triangle of the neck. The base of the axilla is made by the axillary fascia covered by skin. Now, the contents of the axilla include the axillary artery and its branches, the axillary vein and its tributaries, the brachial plexus and its branches, a nerve called the intercostobrachial nerve, which is the lateral cutaneous branch of the second intercostal nerve that supplies the axilla. There are axillary lymph nodes that drain the upper limb and the thoracic wall and back. All these structures are embedded in axillary fat, and in addition, there is a tail from the mammary gland that protrudes into the axilla. Now it's time to test our knowledge. Please pause the video, try to answer the question yourself, and then replay the video to hear the answers. Okay, let's match. The medial wall of axilla. Let's see the ribs. Okay. The lateral wall of the axilla, clavicle, coracobrachialis. The posterior wall, okay, latissimus dorsi. The anterior wall, subclavius. The apex, clavicle. Well, a few things to remember. The anterior wall and posterior wall, each of them is formed of 3 muscles. In the anterior wall, the 3 muscles are arranged in 2 layers: pectoralis major in the first layer, minor and subclavius in the second layer, connected by clavipectoral fascia. The posterior wall, subscapularis, teres major, latissimus dorsi from above downwards. The medial and lateral walls are made of bones and 2 muscles. The bone here is humerus. The 2 muscles are short head of biceps and coracobrachialis. The bones here are ribs. The muscles are intercostals and serratus anterior. The apex is surrounded by 3 bones: clavicle, scapula, first rib. The base is made of soft skin and fascia. The contents are one from each type of structures: the axillary artery, axillary vein, brachial plexus, axillary lymph nodes, axillary fat, axillary tail of mammary gland. Now, in the third part of this lecture, we will study the brachial plexus, how it is formed, its stages, its relations, its branches, and the effects of its lesion. The plexus is made of 5 stages. A stage of roots, stage of trunks, stage of divisions, cords, and finally branches. The roots are in the neck. They are made of the ventral primary divisions of the spinal nerves number C5, 6, 7, 8, and T1. C5 and 6 unite together to form the upper trunk. 7 alone makes the middle trunk. C8 and T1 unite to form the lower trunk. The trunks divide. Each trunk gives an anterior division and a posterior division. The anterior are in green, the posterior are in blue in this diagram. The divisions unite to form cords. All 3 posterior divisions unite to form the posterior cord. The anterior divisions, the 2 divisions of the upper and middle trunks unite to form the lateral cord, and the anterior division of the lower trunk alone makes the medial cord. So each cord is made in a special way. The medial cord is made by 1 division, the lateral cord is made by 2 divisions, the posterior cord is made by 3 divisions. Why they are called lateral, medial, and posterior? That's because of their relation to the second part of axillary artery. The pectoralis minor muscle divides the axillary artery into 3 divisions. First part before it, second part deep to it, third part lateral to it. The cords are related to the second part of axillary artery as their names indicate, so that the lateral cord is lateral to the artery, medial cord is medial to the artery, posterior cord is posterior to the artery. At the lateral border of pectoralis minor, these cords divide, giving their final branches, as we will see. The relations of the brachial plexus, the first 2 stages, the roots and trunks, lie in the posterior triangle of the neck. The roots emerge between 2 scalene muscles, the scalenus anterior and the scalenus medius. The divisions occur behind the clavicle. The last 2 stages, the cords and the branches, lie in the axilla in relation to the second part of the axillary artery. They are related to the axillary artery in the same way as their names tell. That is to say, the lateral cord is lateral to the artery, the medial cord is medial to the artery, and the posterior cord is posterior to the artery. Now we will study the branches of the brachial plexus. At first, we will start with the branches arising above the clavicle in the neck. There are 2 from the roots and 2 from the trunks, actually from the upper trunk only. The 2 important ones arising from the roots, although there are other branches from the roots, the 2 important ones are the dorsal scapular nerve, or the nerve to rhomboids. The second one is the nerve to serratus anterior, or long thoracic nerve, C5, 6, and 7. The nerve to rhomboids is C5. The 2 arising from the upper trunk are the nerve to subclavius, which may provide an accessory phrenic nerve, as we will see later. And the second one is the suprascapular nerve. The infraclavicular branches include branches from the cords. There are 3 branches from the lateral cord. The continuation of the cord is the musculocutaneous nerve, so from C5, 6, and 7. It pierces the coracobrachialis to supply it, and we will study its details in the arm. We have a lateral root of median nerve that unites with a medial root of the median nerve to form the median nerve. And we have a lateral pectoral nerve. Branches of the medial cord include, most of them start with the word medial. So, except one, which is the ulnar nerve. In addition to the ulnar nerve, we have the medial root of median nerve. We have the medial pectoral nerve. We have the medial cutaneous nerve of arm and the medial cutaneous nerve of the forearm. Here we can see them. Here is the musculocutaneous nerve. This is the medial root of median nerve, and this is the lateral pectoral nerve. All these are branches from the lateral cord. In order to understand the plexus well, you have to imagine the letter M. Here it is. This is the musculocutaneous nerve. These 2 roots unite to form the median nerve, and this is the ulnar nerve. Okay. This is the ulnar nerve. This is the medial root of median nerve. These are the branches of the medial cord. Medial pectoral nerve piercing pectoralis minor. Medial cutaneous nerve of the arm and medial cutaneous nerve of forearm. The branches of the posterior cord can be remembered by the word ulnar. These are the beginnings of each branch. The U stands for the upper subscapular, which descends to supply the subscapularis. The L is the lower subscapular, which supplies subscapularis and teres major. The N in between them is the nerve to latissimus dorsi or thoracodorsal nerve. The 2 terminal branches are the A is the axillary artery, axillary nerve or circumflex nerve, and the R is the largest branch or the continuation of the posterior cord, which is the radial nerve. Now we can see them. Here we have pulled upwards the branches of the medial and the lateral cords. Here they are, to see the posterior cord and its branches. This is the upper subscapular. This is the lower subscapular. This is the nerve to latissimus dorsi. This is the axillary, and this is the radial. Okay, now we will study the injury of the brachial plexus. Injury of the whole plexus may lead to paralysis of all muscles of the upper limb, except one muscle, which is the trapezius. Trapezius is a large muscle in the back. Because the trapezius is supplied by cranial nerve, which is the spinal accessory nerve. In addition, all sensations from the upper limb are lost, except only 2 regions. On the upper half of deltoid, because the lateral supraclavicular nerves supply this region, and they come from the cervical plexus, not from the brachial plexus. And in the upper medial side of the arm, because this is supplied by the intercostal brachial nerve or the second thoracic nerve that comes from the second intercostal nerve. Now we will describe the lesions of the trunks. We have upper trunk lesion and lower trunk lesion. Upper trunk lesion is called ERBS paralysis. It occurs during delivery of the child. After the delivery of the fetal head, the body is still inside. If the doctor handles the head roughly, abducting it on one side strongly, this causes stretch on the upper trunk in its central point, which is called ERBS point, that ruptures. This will lead to motor manifestations and sensory manifestations. The motor effect is called policeman position or tip position. As you can see, the arm and forearm are by the side, and the hand is backwards because there is pronation. C5, 6, and 7 supply muscles of the shoulder, which are mainly abductors and medial rotators of the shoulder, muscles of the front of the arm, that include the biceps, which cause flexion and supination of the forearm. So due to paralysis of these muscles, there is abduction of the shoulder, there is medial rotation, and in the forearm, there is extension and pronation. There is loss of sensation or anesthesia on the lateral side of the arm and forearm. These are called dermatomes of C5 and C6. The dermatomes are, each dermatome is an area of skin that is felt by one segment of the spinal cord or reach the dorsal root from one spinal nerve. The dermatomes of the upper limb include everything from C4 till T2. The middle three ones, C6, 7, and 8, are in the hand. C6 is lateral, C8 is medial, C7 is in the middle. They extend to the forearm. In the arm, above C6, we have C5, then C4 laterally. Medially, we have, after C8, we have T1 and the T2 in the axilla. So the sensory loss here, 5 and 6, is on the lateral side of the arm and forearm. Now we'll come to the lower trunk lesion, C8 and T1, Klumpke's paralysis. The cause of this injury is usually hyperabduction injury. Like, for example, falling and holding to something, like the fence of the balcony, branch of a tree, or falling from a running bus and holding to something. All these hyperabduction injuries cause injury to the lower trunk. The effects is C8 and T1 supply mostly the muscles of the hand. Muscles of the hand, as we will know later, are responsible for what is called writing position. Writing position means flexion of the metacarpophalangeal joints and extension of the interphalangeal joints of the finger. Imagine yourself holding a pencil and see how the writing position is. Reverse this and you will get the deformity, which is called the claw hand. Claws are like the claws of an animal, so the fingers become clawed. This is due to a hyperextension, reversal of the writing position. Writing position was flexion of metacarpophalangeals, so the reversal is hyperextension of metacarpophalangeal joints. And in writing position, there is extension of interphalangeals. In the claw hand, there is flexion of the interphalangeal joints. The anesthesia will be on the medial side of the arm and of the forearm and hand because it's C8 and T1. The details of the branches of the brachial plexus will be studied in the regions that they supply. So here we will study only 3 nerves that supply the pectoral region. The first nerve is the long thoracic nerve, or the nerve to serratus anterior. It arises from the brachial plexus, from the roots of the brachial plexus, C5, 6, and 7 in the neck. It pierces the scalenus medius muscle, descends behind the plexus on the surface of the serratus anterior muscle supplying it. Its injury sometimes occurs during the operations of cancer breast, in the operation of radical mastectomy. It leads to what is called winged scapula, especially when pushing the hands forwards against resistance, like pushing the wall. The medial border of the scapula will protrude backwards. The second branch is the nerve to subclavius, which is a branch of the upper trunk. It descends in front of the brachial plexus to behind the clavicle to reach the subclavius muscle. It gives a root to the phrenic nerve that may form the accessory phrenic nerve. Its importance is that in the past they used to crush the phrenic nerve to cause paralysis of the leaflet of the diaphragm in order to cause collapse of the lung as a very old treatment for pulmonary tuberculosis or TB. Sometimes when they crushed the phrenic nerve, they noticed that there was no collapse of the lung. The reason was due to presence of accessory phrenic nerve. It's historical matter. Now the two pectoral nerves, the medial and the lateral, they are branches of the trunk of the cords of the brachial plexus, as their names indicate. The medial pectoral is smaller than the lateral pectoral. The origin, the medial pectoral is a branch of the medial cord. The lateral pectoral is a branch of the lateral cord. So the root values are the medial pectoral C8T1, the lateral is C567. The medial pectoral pierces the pectoralis minor, while the lateral pectoral pierces the clavipectoral fascia. After that, both of them supply the pectoralis major. Their position is contrary to their names, so that the medial pectoral, which pierces the pectoralis minor, is actually lateral in position, while the lateral pectoral is medial in position because it pierces the pectoralis minor. So why they are called so? Because of their origin from the cords of the brachial plexus. They both supply both pectoral muscles, pectoralis minor and pectoralis major. How is that? Because they have an intercommunicating ramus, so that fibers from both pectoral nerves supply both pectoral muscles. Now it's time to answer a few questions, whether the statements are true or false. Stop the video, please, and try to answer yourself. Then replay the video to hear the answers. Okay. The first statement, the medial and lateral pectoral nerves are located as their names indicate. Of course, no. At the beginning, yes, they are medial and lateral because they arise from the medial and lateral cords as their names indicate. But at their ends, they are reversed. The lateral pectoral pierces a medial structure, which is the clavipectoral fascia, while the medial pectoral pierces a laterally located structure, which is the pectoralis minor. Second statement, motor effect of upper trunk lesion are generally proximal, while effects of lower trunk lesion are generally distal, whereas sensory effects are lateral and medial respectively. Okay, regarding the motor effect, yes, the upper trunk supplies shoulder and front of arm muscles, which are proximal. Lower trunk supplies intrinsic hand muscles, which are distal. So the motor part or the first part of the statement is correct. Regarding the sensory effects, the upper trunk has dermatomes C5 and 6, which are located laterally. The lower trunk has dermatomes C8T1, which are medial. So the whole statement is correct. Okay, the brachial plexus supplies every muscle and every skin segment in the upper limb. Of course, wrong. Why? because one muscle is not supplied by the brachial plexus, which is trapezius, supplied by spinal accessory, which is a cranial nerve. And also two segments of the skin are not supplied by the plexus. Skin of the shoulder and skin of the armpit are supplied by nerves, not branches of the brachial plexus. The last statement is T1 root is somatic and autonomic. Well, let's think. Yes, it shares in the brachial plexus, having sensory and motor actions. So it is somatic, but it is still also autonomic, particularly sympathetic, because, as you know, the sympathetic outflow includes thoracolumbar segments of the spinal cord, beginning from T1 till L2. So T1 root carries somatic fibers and sympathetic preganglionic fibers, which leave it as white ramus communicants to join the sympathetic chain. Now we reach the end of this lecture. Thank you for listening. If you like these lectures, please subscribe to my YouTube channel and hit like. Thanks again.